All attendees are in listen-only mode.
Good afternoon, everybody. Thank you for joining us today for a webinar presentation on mental health parity, assuring that there is equal access to treatment for children with special needs. And before, didn't turn off my Outlook. Before I introduce Nancy Shea, our wonderful speaker, I'm just going to tell you a little bit about Family Voices of California. These presentations that we have on monthly statewide training topics which affect children and youth with special healthcare needs, and our webinars are geared towards very diverse groups which include families, professionals, parent-to-parent, resource staff, advocates, and more. So Family Voices of California is a statewide coalition of locally based parent-run centres working to ensure that children and youth with special healthcare needs receive quality healthcare. And as the state affiliate of the National Family Voices, we are California's federally funded family-to-family health information centre providing statewide support to families. So just a few notes about the technology that we're using. If you don't have a headset for your computer, you can join us by telephone by dialing into the number that you see on your attendee screen panel. And if you have any difficulties, technical difficulties, please just go to webinar directly at the number on the screen here. And owing to feedback issues, we have everybody on mute from our end. Throughout the webinar, feel free to type in any questions that you might have for Nancy. You've got a question box on the right-hand side menu of your panel. We'll have about 10-15 minutes at the end of Nancy's presentation to take questions. Today's presentation is being recorded and will be posted on our Family Voices website after the webinar. And also you're going to be receiving a very short survey to evaluate today's presentation. We really appreciate if you take the time to complete that. It's just a couple of minutes. Your feedback really is invaluable to us. So now it is my pleasure to introduce Nancy. Nancy is the Senior Attorney at Mental Health Advocacy Services, Inc., which is a public interest law firm in Los Angeles. Nancy is a graduate of UCLA Law School and is an expert on issues involving children's mental health and the coordination of services to children who have serious emotional and developmental disabilities. She's also an expert on the education of children in the foster care and probation system. In 1989, Nancy began representing children with special needs who were under the jurisdiction of the Dependency or Delinquency Court. And over the years, Nancy has provided technical assistance and trainings on education and mental health matters to attorneys, bench officers, social workers, probation officers, caregivers, and youth. She has advocated for legislative changes as well as litigated several significant cases which have led to reforms in the delivery of service to children with special needs. Nancy has co-authored a number of journal articles addressing the education issues that children and youth foster care and probation systems encounter. And for the last 3 years, Nancy has focused on the implementation and the enforcement of the California and federal mental health parity laws, especially as they impact access to mental health for children and youth. She's a member of the board of the California Mental Health Advocates for Children and Youth. So thank you, Nancy, for joining us today to present. I'm going to hand it over to you.
Okay, thank you. Good afternoon. Welcome to this presentation on mental health parity. First, let me say that it has been a difficult few months with not knowing whether or not the Affordable Care Act would be repealed or replaced or whatever. And the status of the ACA does have an impact on how much we can rely on the rights afforded by the mental health parity laws. As of today, there are no changes, so I'm going to proceed from that place. What I say today is what the law is today. I just can't guarantee what it will be tomorrow. Most of the work around mental health parity has focused on adults, but the same laws also apply to children and youth, and that is something I've been working on with a grant from the Robert Ellis Simon Foundation, making parents aware that their insurance should be available to provide appropriate mental health treatment for their children. Today, this webinar will cover these 4 topics: why this matters, what is mental health parity? That's just basically a definition of what we mean by mental health parity. An overview of the mental health parity laws under state and federal laws, and how to challenge decisions and policies of insurance companies when it comes to assuring a child receives appropriate services. I always start out with some statistics to make clear the severity of the issue we are facing. These numbers are from the National Alliance of Mental Illness, citing statistics from the National Institute of Mental Health. The top line, 20% of youth ages 13 to 18 live with a mental health condition. That is 1 in 5 children. Suicide is a 3rd leading cause of death of youth ages 10 to 24. This slide shows the percentage of public school students reporting whether in the past 12 months they felt so sad or hopeless almost every day for 2 weeks or more that they stopped doing their usual activities. And these numbers are from the California Department of Education's Healthy Kids Survey and was published by kidsdata.org. But look at the 11th graders. That's a third, almost a third of 11th graders report not just 1 day of feeling sad or hopeless, but almost every day for 2 weeks or more. This is from actually a Family Voices presentation by Children's Hospital of Orange County. And we know that children that have both chronic illness and a disability are at greater risk for psychiatric problems. "50% of all lifetime cases of mental illness begin by age 14 and 75% by age 24. The average delay between onset of symptoms and intervention is 8 to 10 years. This emphasizes the need for early identification and treatment." So, why does this matter? Approximately 50% of students age 14 and older with a mental illness drop out of high school, and 70% of youth in state and local juvenile justice systems have a mental illness. So this is just some of the troubling news, and why we need to look at as many resources as possible to assure that our children and youth receive the services that they need in order to grow to be healthy, responsible adults. Why do we need laws, parity laws, to regulate insurance coverage? Historically, insurance companies have provided unequal coverage between physical health care and mental health care. This has been a form of discrimination that is rationalized by the stigma that often attaches to mental illness and substance use disorders. You know, these aren't really serious conditions. It's all in your head, or you're just weak, or you just get on with it. So here are some examples of parity. Insurance companies can have a $15 copay for outpatient medical visit and a $20 copay for outpatient mental health visit. They can have 21 inpatient days for mental health care and 30 days for inpatient physical health care. They can't require prior authorization for mental health services and not for physical health services. And actually, this has been a fairly common violation of the parity laws. Another interesting example that has come up is that if your total annual deductible is $500, you can split that between medical services and mental health services. And a plan cannot make you pay $500 toward a medical deductible and another $500 for a mental health deductible, because that would be $1,000. So Parity in health insurance means that a person receives coverage for mental health services that are equal or equivalent or comparable to what they receive for physical health care. It's important to underscore here that parity does not mean a strict equivalency between physical health coverage and mental health coverage. And I'll talk a little bit more about that later. So, to understand mental health parity, we need to know what the laws are that govern it. We have both federal laws and California laws, and I will touch on both of them. The first federal parity law was actually passed in 1996 and applied only to certain group plans that had aggregate lifetime limits or annual limits. It was in 2008 when the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act, that's a real mouthful, was passed. This broadened the federal parity requirements, but it said if a plan offered any mental health or substance abuse benefits, the plan must provide these benefits at parity to medical and surgical benefits. But they didn't have to provide mental health benefits. And finally, in 2010, the Patient Protection and Affordable Care Act was passed, and it extended parity to additional plans, it expanded appeal rights, and most importantly, it mandated that 10 essential health benefits, including mental health and substance abuse benefits, be included. So as of now, mental health and substance use abuse benefits must be included in every plan covered by the ACA, and that is actually most plans. California passed its own Parity Act in 1999, just 3 years after the first federal parity law. It applies to those plans that are regulated by the state of California and requires a policyholder to meet certain eligibility criteria. So I'm going to talk about the California plan first, or the California law first. It applies to those plans that are regulated by the California Department of Insurance or the California Department of Managed Health Care. How do you know who regulates your plan? That information is in the evidence of coverage, which is that fat book you should get from your insurance carrier that describes your benefits. Or you can call either regulatory agency and ask. I actually have a slide with their contact information later on in this presentation. You can also just call your health plan and they should tell you. So, the following plans are not covered by the California Mental Health Parity Act, and those include federal plans as well as some self-funded plans that are offered by employers and unions. So Medicare, Medi-Cal, Veterans Administration health plans, those are not covered by the California Mental Health Parity Act. Now, to whom does the California Act apply? Adults with a severe mental illness, and by adults we mean anyone 18 years old and older, children with a severe emotional disturbance. And what do those terms mean? Well, for adults, we have a list of 9 specific diagnoses. If you don't have one of these diagnoses, then the California parity requirements do not apply. It's as simple as that. How did the legislature come up with this list? Frankly, I have no idea, but this is the list that we have. Major depression, bipolar disorder, schizophrenia, schizoaffective disorder, anorexia, bulimia, obsessive compulsive disorder, autism or pervasive developmental disorder, and panic disorder. Now, autism is not in the current DSM-5, but the statute hasn't changed. So I would hope that a diagnosis of autism spectrum disorder would work. I haven't encountered that as an issue, however. For children, eligibility is a bit more complicated as it goes beyond a simple diagnosis. It is tied to the definition of eligibility for the California Children's System of Care. Child must be under the age of 18 years and has a diagnosis from the most recent edition of the DSM other than a primary substance use disorder or developmental disorder, which results in behavior inappropriate to the child's age according to expected developmental norms, and must meet the criteria of Welfare and Institutions Code, sections 5600.3A2. And what is that criteria? Well, it means there's a substantial impairment in at least two of the following four areas: self-care, school functioning, family relationships, and ability to function in the community. So you have to have two of those areas. And in addition to that, one of the following occurs: at risk of removal from the home or has been removed from the home, impairment has been present for more than 6 months or is likely to continue for more than 1 year with treatment, displays one of the following: psychosis, risk of suicide, or risk of violence, and is identified as eligible for special education as emotionally disturbed. So you need one of those four conditions. So let's take Anthony. He's 13 years old and has a bipolar disorder diagnosis. He qualifies for special education under the emotional disturbed criteria. He is at risk of being removed from his home because his parents cannot control him. He has a substantial impairment in school functioning. He's suspended and been threatened with expulsion. And the family relationships: again, he is out of control at home. So most likely, he would qualify under the California Mental Health Parity Act. Now, what if you don't qualify as either an adult or child? Well, we still have the federal law, which I will get to in a minute. But first, what the coverage, like California law requires, that coverage must be equal in terms of these three items: lifetime benefits, co-payments, and deductibles. The coverage must include these four services: outpatient and inpatient services, partial hospital services, and prescription drugs, but only if the plan covers any prescription drugs. So if prescription drugs is not part of the plan, then it doesn't matter. It's not going to be covered. And we have something in the California law. This is the coverage mandate. And I want to focus on what is meant by all medically necessary treatment. And that is because of two recent court cases, one in federal court and the other in state court. Both involve a young woman diagnosed with anorexia, and both courts have held that the health insurance plan had to pay for residential treatment because it was medically necessary, even though there was not an analogous treatment available for physical health. Both courts rejected the idea that parity means strict equivalency between mental health treatment and physical health treatment. Instead, they recognize that mental health treatments are unique and cannot be restricted to those that are identical to physical health treatment. For instance, outpatient treatment for cancer is not the same as outpatient treatment for depression. Under REA, the treatment must be sufficient to reach the same quality of care afforded to physical illnesses. So we're not looking at treatment per se being equal, but at the outcome, which is the same quality of care. Now I'm going to turn to the federal law. First, the Affordable Care Act. These are the three important parts of the ACA as it applies to parity: created the 10 essential health benefits, expanded existing federal parity laws to more health plans, and expanded appeal rights to more health plans. Initially, in the early discussions about repeal and replace of the ACA, there were all sorts of guarantees that the 10 essential health benefits were safe. And there was a special attention to the mental health and substance use disorder services, but that didn't last very long, and they were soon eliminated in the initial drafts. What is the impact on mental health and substance use disorder services? Well, an insurance plan would no longer be mandated to provide these benefits. They could, if they so chose to do so, provide them, and then they would have to provide them at parity with physical health benefits, but they could also drop this coverage, and that would be really very serious for so many people. So this is the main federal parity law, Mental Health Parity and Addiction Equity Act of 2008. The ACA did significantly expand the number of plans to which parity must be applied, and it is clear that almost all plans now must provide these benefits at parity with medical and surgical benefits. So you have the employer-based plans. Those are employees where there are more than 50 employees. What's called the qualified health plans in California. They're known as the Covered California plans that are purchased on the exchange. All individual plans, most small group plans, and Medi-Cal managed care plans, and the Medi-Cal benchmark and benchmark equivalent plans that are known as the Medi-Cal expansion, which brought many people coverage. For the last two, regulations implementing parity were promulgated last year and will become effective at the end of September of this year. So far, those regulations are still in place. So under Medi-Cal managed care and under the Medi-Cal expansion plans, parity must be in place. They do not apply, the ACA does not apply to certain grandfathered small group plans, as well as Medicare Part A and Part B, but it does apply to Medicare supplement plans, and it also does not apply to the full scope Medi-Cal plans. Also doesn't apply to Veterans Administration health plans and to TRICARE, which is an insurance plan for those in the military. Now, under the final regulations, every benefit must fit into one of these 6 categories. However, the federal laws do not define outpatient or inpatient, instead leaves that up to the individual plans, but they must be consistent with generally recognized standards of medical practice. And the plan must apply these terms uniformly for medical surgical benefits and for mental health or substance use disorder benefits. So quantitative treatment limits. Limits typically refers to any maximums that a health insurance plan imposes on specific benefits. And remember, any limitation must be imposed equally between mental health and physical health benefits. Figuring out quantitative limits is fairly easy to spot and analyze. These limits have a number attached. It's a violation of parity laws when access to treatment for mental health and substance use abuse is more limited, or when the out-of-pocket costs for mental health treatment are higher than for physical health care. And let's just take number of visits as another example. If there are no annual limits on the number of office visits to see a doctor to treat the flu, there can be no limits to see a therapist for depression. Non-quantitative treatment limits are a bit more complicated. They are any non-numerical process, strategy, standard, or other factor that limits treatment benefits. Consider step therapy, for example, where a patient is required to try a cheaper treatment first before allowed access to a more effective and expensive alternative. It is a violation of parity law if step therapy is required for mental health treatment, but not for physical health care. Also, requiring prior authorization for mental health treatment, but not for physical health treatment, is a violation of the parity law. Restrictions based on geographic location, which makes it impossible for someone to get to an appointment. Restrictions on type of facility, provider specialty, and other criteria that limit the scope and duration of mental health and substance abuse disorder benefits more than physical health treatment are also a violation of the parity law. This is an area that's ripe for interpretation. Now, I'm going to turn to the appeals process. And why is this so important? One of the biggest weaknesses of the parity law is that it requires consumers to enforce it. In California, both the Department of Insurance and the Department of Managed Healthcare have done some enforcement work, but it is limited. I was at a statewide conference recently where a deputy director of the Department of Managed Healthcare said that it is critical that complaints and appeals get filed because that is the best way they have of knowing what is going on. She was literally begging for complaints to come into her office. Nationwide, more than 50% of appeals of denials of coverage or reimbursement by health insurance are successful in favor of the covered individual. Current statistics for the California Department of Managed Healthcare's website show that a denial is overturned 60% of the time. The Department of Insurance is about 50% of the time. Just because the process can be long and complicated does not mean it should not be done. Even individuals often do not win at the first level of appeal, and success is more likely with ongoing and persistent appeals. Most insurance plans in California are regulated by either the Department of Managed Healthcare or the Department of Insurance. There are other federal regulatory agencies such as the Department of Labor and the Center for Medicare and Medicaid Services, but since most commercial plans are under the state, I'm going to focus on their process. So, first, health care service plans are regulated by the California Department of Managed Healthcare. And what do I mean by them? Those are plans that are prepaid health plans which contract to provide services when needed. HMOs are healthcare service plans. Blue Cross and Blue Shield, preferred provider organizations, also known as PPOs, are also regulated by DMHC. The website that I have here is actually very helpful and has a lot of good information on it. For health insurance, however, this is a type of indemnity insurance, which means that reimbursement for health care cost is on a fee-for-service basis. These plans are regulated by the State Department of Insurance. They also regulate other forms of insurance, including fire, home, or automobile. Again, their website is very useful. As I've been told that between these two agencies, they regulate about 80% of all the health plans in California. As stated earlier, if you don't know who your regulatory agency is, either check your evidence of coverage or give either agency a call and they will tell you, or again, you can just call your carrier. In most cases, you must first exhaust your health plan's internal appeals process before requesting an external review of the insurance company's decision. And this would occur when the plan denies, changes, or delays a service of treatment because it is not medically necessary, it is experimental or investigational treatment, or it involves emergency services that already have been received. Not medically necessary is a term that insurance plans often use to deny coverage. The problem is that the term is opaque and often seems to violate accepted professional standards. Recently, there has been a number of lawsuits filed that are challenging these internal guidelines and could have far-reaching effects on the managed care industry, which commonly uses these proprietary guidelines, which means that they can't show them to adjudicate claims. So they tell you no, but you really don't know why. Obviously, you must be given sufficient notice to effectively file an appeal before the termination or reduction occurs. Most health plans have a fairly simple process for submitting an internal appeal. There's usually a form and instructions attached to your denial notice. This just means that the insurance company takes another look at the claim. At the possibility of sounding maybe a little bit cynical, some believe that the initial claim is denied, knowing that an appeal will never be filed. But if the appeal is filed, then the denial will be overturned. There may be one or two levels of internal appeals that you do have to go through, and you must have a resolution within 30 days. Now, if the insurer denies your requested service after you file an internal appeal, you have the right to take your appeal to an independent third party for review of the insurer's decision. Under California law, you have 6 months to file a request for an independent medical review with the DMHC or Department of Managed Healthcare or the Department of Insurance. There are some exceptions, but the notice sent to you by your health insurer should specify the time frame in which you must make your request. Members of the independent review organization must be individuals who are qualified to conduct the external review and must have no conflicts of interest that may influence their decision. Consumers must be allowed to submit additional evidence in writing to the review organization that must be considered when conducting the external review. The websites of both of these agencies have a form you can use, and it's fairly simple to fill it out and send it in or submit it over the internet. Now, what if it's an urgent situation where waiting jeopardizes the life or the ability to gain maximum function? In an internal and external review can be requested at the same time, and a final decision must be reached within 4 business days. Having said some positive things about DMHC, however, I will add that they were sued last year for taking more than a month to reach a final decision in urgent health situations. I understand that they have made some changes or are attempting to make some changes in their processes. So the difference between 4 business days and a month is quite a critical length of time. When it is a matter of a denial or when it isn't a matter of a denial or termination of service, but you have a general complaint about the operation or procedures of your health plan, what do? Well, you can file what's called a consumer complaint. And some of these problems might be delays in getting an appointment, referral or authorization, claims, billing or co-payment issues, terminations or cancellations of coverage, access to translation and interpretation services, finding an in-network doctor, hospital, or specialist, complaints about a doctor or a plan, or a doctor or hospital is no longer with your health plan. For any problems regarding the operation or procedures of your health plan, you can file a consumer complaint by going either to the DMHC website or the DOI website and filing the complaint. This is really the only way to hold insurance companies accountable to following the law. Here's a question for you. At the end of this, can you file a lawsuit in court if you disagree with the result? Yes, but in most cases, you will be required to go to binding arbitration because in the fine print, when you signed up for your coverage, you agreed, whether you know it or not, to binding arbitration. And generally, an appeal of that, generally you can't appeal that end result. Most court cases that we see involve what are called ERISA plans, and that's because there's actually statutes allowing you to go into court. But as I said, most of the plans in the state, and we're looking at about 80% of them, do not fall under the ERISA plans. So, An example where a complaint is appropriate: timely access to care. Guidelines from the Department of Managed Healthcare state that 10 business days is the maximum amount of time allowable for getting a mental health appointment with a non-physician. So this is anybody other than a psychiatrist, basically. So you call your provider and ask to see a therapist, and they give you an appointment in a month. Your next call should be to DMHC or DOI, because clearly they are in violation of these guidelines. Here are some tips for appeals and complaints. First, understand your health plan coverage. This is critical. You really need to know what's in your plan, what's available, what you can get, and what's not available under that plan. Second, keep asking and appealing. Denials frequently get overturned at every stage of the process. Keep your appeals factual and brief, but make sure you provide complete information and meet all deadlines for filing an appeal. If you do miss a deadline, a denial is seldom overturned. Keep detailed records, and this includes every call made and its outcome. Ask for help from your health providers. And this may be one of the most important ones because they have the resources and knowledge to support your claim. They are the ones who are recommending the type of treatment that you should be getting. So they really need to be involved in this process. Get a reason for denial in writing. If you request it, your insurer must provide the name, the title, and credentials of the person who made the decision, the medical review criteria used, and the instructions for obtaining additional assistance. And 4, call the insurance company about the status of the review and keep following up until you receive an official or final response in writing. Let them know that you are not going away. And finally, the lesson learned from this, I hope, is don't take no for an answer, because you may very well get to yes. This is just give you my contact information here. And this is a disclaimer. Because some of these laws may very well be changing, it's important that you don't rely completely on what I've said here. And thank you.
Thanks, Nancy. We do have a couple of questions. Does the federal parity law apply to self-funded plans for severe depression or bipolar disorder in California?
Wait, I just did something I shouldn't have done. Hold on.
Maybe back to that slide where it has your contact.
Yeah, that's what I'm trying to get to.
The second half.
Could you repeat the question again?
Yeah,
I'm sorry.
Yes. Does the federal parity law apply to self-funded plans for severe depression and bipolar disorder in California?
The federal parity law, yes. When you're looking at a diagnosis, you're really just looking at the California Mental Health Parity Act. You're not looking at the federal law. The federal law does not rely on a diagnosis.
Okay. And this just popped up. Somebody on one of the attendees said that please note that under state mental health parity, the Health Safety Code section 1374.72, a severe mental illness applies to a person of any age, not just for adults, but at any age. That there was some clarification on that 1374 code.
Okay.
Let me see if there's some more questions. Regarding, many people have asked, yes, the handouts are going to be available, Nancy's PowerPoint presentation slides are available on our website later this afternoon, as well as the full recording. So you can access our website as www.nancyshea.org. familyvoicesofca.org, and you go to the webinar archive webinars tab, and you can get copies of Nancy's presentation. Nancy, another question regarding the 10 business day max for non-urgent mental health appointments. What does this mean? What does this mean for agencies that don't have openings and clients are placed on wait lists?
Well, isn't that interesting?
Yeah.
It should mean that this is why getting the state agency involved becomes quite important. They should not have to wait beyond the 10 business days. That's in violation of these guidelines put out by the state. So there should not be that kind of waiting list. And again, the only way that the state really has of enforcing this is knowing what the issues are. Now, what can the carrier do? Well, they can refer you to somebody out of network,
Yeah.
which they don't want to do, but that's what they can do.
Well, legally, they have to do that if they can't.
If they can't serve you in network, they need to refer you out of network, but they don't like to do that.
Okay. Another point somebody has made: how can people that get themselves into situations where they don't know where to go next? How can low-income families get assistance from attorneys at your organisation, Mental Health Advocacy Services, and what is the cost for families?
This is a real problem because it's been a real problem in terms of implementing mental health parity across the country, whether we're talking about our state law or the federal law. There are no resources, frankly. My agency at this point can't take individual cases because of our own limited funding. I certainly am willing to give information over the phone, but I can't take individual cases. It's a real problem, and there are no attorney's fees attached to this. You know, I spend a lot of time doing special education appeals, and I will tell you, one of the real powerful things about working on special education was that attorney's fees were attached. Yeah. And you remember I talked about ERISA plans. Well, if you're under an ERISA plan, then there are attorney's fees that may be available there. It's a real problem. That's why I do like to refer people to the website of Department of Insurance and the Department of Managed Health Care. They do. It's very user friendly. DMHC's if you call their number, they actually are quite helpful, believe it or not, in providing assistance, in answering questions and directing people. But just in terms of really dealing with some of the most difficult issues, it's difficult. That's what I have to say.
Thank you, Nat. Do those Department of Managed, do they have people that speak in other languages or interpreters?
Yes, they do.
Okay.
Yeah, they do.
Another attendee is asking, given that it can take quite a while to get a mental health diagnosis for an adolescent with a serious mental illness, for example, schizophrenia, how does that impact the ability to get treatment covered by your health plan?
Well, again, if you're looking at the California Mental Health Parity Act, then it might have an issue because you're looking for a diagnosis. But if you're looking at the federal parity law, that's a little bit different. They do not require diagnosis. So you need mental health services. Yeah.
Okay, and how does mental health parity intersect with the EPSDT benefit in Medi-Cal?
Oh, two different funding sources. EPSDT is the full scope Medi-Cal program, and they're not covered by the Mental Health Parity Act. Now, however, if you're getting, if you're in the Medi-Cal managed care plan, or if you're part of the Medi-Cal expansion plan, they will come under the Mental Health Parity Act. But if you've got full scope Medi-Cal, it doesn't apply.
Okay. One attendee has written, my daughter is 27 and is on a self-funded group plan provided by her husband's company in California. They are limiting the number of TMS treatments that she can receive, the transcranial magnetic stimulation treatments, that is FDA approved, and they do cover. Medication does not help with severe depression. Can they limit the number of visits, being it is her only form of treatment?
A lot of to fully answer the question, you kind of know what they're also allowing for physical health treatments, but I would say I mean I would really question the limitation and really push, you know, why they are limiting it. You know, what's their rationale for it? Are they doing the same kind of limitations for any kind of physical health treatment?
Okay. The person who was asking about the 10 business day max for non-urgent mental health and the wait lists, she just also saying, I work primarily with children who are covered by Medi-Cal. Does the 10-day max apply to them as well?
That's a good question. Why not? I mean, I don't mean to be real flippant about that, but because what I really focused on are Mental Health Parity Act as it applies to commercial insurance plans. But DMHC also has some enforcement of the Medi-Cal. I need to look something up to fully answer that. So if I could have,
I will send these questions to you after the webinar, Nancy, so you can refer back to them.
Okay.
Okay. No more questions have come in. If any of the attendees that are still on do have further questions, I had asked Nancy before the webinar started, you could send them to me and I can send them on to her. That's still okay, Nancy? And you can answer them via email. So I just want to let everybody know that next Wednesday we have Family Voices having another webinar, and it's on Medi-Cal services for children on the autism spectrum disorder. So I will send that. I'll send that link for the registration to you all after we're done here. So thank you, Nancy, again. Thank you very, very much for wonderful information. So we're coming to a close. Nancy, is there anything else you wanted to add before we close?
No, just that I just cannot emphasize how important it is to challenge insurance companies on their decisions. As I said, it is the only way to hold them accountable.
Yeah. Very true. Well, thanks everybody for joining us, and I do appreciate it if you take the time to fill out the short survey that you'll be receiving.
Actually, there is one other thing that I would like to add.
Sure.
That if people would be willing to, in addition to questions, to send any of their experiences they've had in either challenging insurance companies or the responses they've gotten, or some of the other issues that they've had come up in being denied services.
Yeah, excellent. Okay, everybody, I will be sending you the slides, but you'll also at the end of the day, you can locate the full recording and slides on our website. Thanks a lot. Bye.
And thank you.
Bye-bye, Nancy.